Hello guys, welcome to our channel. Today we will be discussing of the surgery, the most important subject and the scoring subjects. So those who are new to this channel, please do subscribe and share with your friends and do like the video so that it will reach the more students to have the preparation smoothly. So if you want to avail these notes, you can join the Telegram group and you can text me from there. So let's start the discussion guys. This is one of the most important subjects. So that's why I have divided into the part 1 and also part 2. Okay, so this is how we are going to divide it as a two parts. So let's discuss. So daily we will be discussing about the one of the most prominent persons of their respective subject, right? So today I want to discuss about the one of the my most inspirations, that is my father. He is a general surgeon, so he's the most passionate surgeon that I have ever seen. So he has came from the village and he has built his all everything from the zero. He has started the clinic and he has done the many great. He has worked with the many institutions such as Usmania and also Kaktiya Medical University in our Telangana region. So one of the best doctors and one of the best surgeons that I have ever seen, and he has still today also he work with the most passion. So as we are daily discussing about the 1%, so today I want to share about my father also. So let's start the discussion, guys. So we will be discussing of the part 1 and the part 2. So part 1, and today I'm going to include only the general surgery, whatever the basics that we are going to discuss, and then trauma. So trauma is most important, and then the breast, and also thyroid conditions, and also vascular pediatrics. Okay, pediatrics also. So this is included in the part 1. Next, coming to the part 2 is mostly GIT and the urology. Any miscellaneous topics that we will be discussing in the part 2 only. That is what. So the first part will be including. So let's start the first part. So first part we will be including of the normal, right? General surgery only we will be seeing. So in the general surgery, yesterday also I have discussed what is the daycare surgery, what is the protocol that we are going to follow. Same as here also. But in the surgery's perspective, we will be using the ERAS protocol. We are using the ERAS protocol. ERAS protocol means enhanced recovery after the surgery that we are going to use. So we have the pre-operative and we have the intra-operative. What is the protocol that we follow? And also we have the post-operative protocol. These are the protocols that we are going to follow. So first, pre-op protocol. For example, the patient is came. So we will be just counseling how the surgery is going to done. Next, if the surgery is planned, what we will be doing? We will be keeping the patient on the NPO to prevent the patient has to be go under the normal without aspiration and complications. Next, the bowel should be cleared, right? So the bowel clearance should be there for the patient, but it is always till the patient should have a physiological bowel clearance only. We should not give the enema because it sometimes can cause the mechanical preparation is not good for the patient fluid imbalance. Next, the patient is came intra-operative. So in the intra-operative, we are going to make sure that the patient is maintain the vitals. Okay, vitals has to be maintained in the patient. So that is the first thing. And adequate analgesia is provided with the help of anesthesia. Okay, anesthesia related analgesia only, not the NSAIDs should not be given. And also we are going to give the vomiting prophylaxis with the ondansetron. Okay, ondansetron is given for this patient, and no tubes is used. No tubes is used. For example, NPO or the nasogastric tube or the OGT. This tube should not be used. It all has to be used either pre-op or the post-op only. Next, post-operative, what we are going to give. Now we are going to use the NSAIDs for the analgesia. This is the first thing, and the protocol that you have to follow within the 2 hours, the patient should be broken with the NPO. So we have to give the IV fluids, and these IV fluids within the 24 hours of the day. After the 24 hours, you have to stop the IV fluids, and also the patient has to be started in the regular diet and also ambulate. So this is how we are going to follow the ERAS protocol for the patient. Next, coming to the surgical positions, which of the surgical positions we use? So the most commonly we use is the supine position. This is done for the abdominal surgeries, breast surgeries, vascular surgeries, and the cardiac surgeries. Next, another position, that is a prone position. This is for the spinal surgeries and also pilonidal surgeries, right? In the whatever these spinal surgeries or the gluteal surgeries we will be following. Next, lateral position. Lateral position for the thoracic and the kidney. Lithotomy position for the gynecological, urological and the rectal. And the Sims position is for the rectal. And the knee chest position, this is for the spinal and the rectal positions. And reverse Tredelenburg position. So reverse Tredelenburg is the head is upward. So this is for the upper abdominal surgeries. Next, we also have the Tredelenburg surgery. Tredelenburg position. In the Tredelenburg position is opposite, right? So the legs is up and the head is down. Legs is up, this is down. So this is used in the pelvic surgeries. And fovlier position, this is for the neurosurgery and the shoulder surgery. But the one point that you have to remember, the fovlier surgery is associated with the air embolism. This is associated with the air embolism. Next, types of sutures. Types of sutures also has been asked in the previous examinations. For example, we have the simple interrupted suture. Here you can see this is a continuous running suture, and this is the vertical matrix, and this is the horizontal matrix. This is a subcuticular. Most of the times it is for the cosmetic. And persisting sutures around the one of the closure circular wounds, we are going to use the persisting appearances of the sutures that we are going to use for the patients, right? Next, coming to the types of the sutures material. What is the types of the suture material that we are going to use in the patient? So we have the two types of the sutures material. One is the observable sutures and other one is the non-observable suture material. So in the observable suture materials, we have the braided type. What is the braided types, guys? So that is the catgut or the chromic catgut. These are the braided, and also which is known as a natural type. These are the natural type of the uses. And what is the example? That is, we have surgical gut. So in the surgical gut, what we use commonly is we use for the patients whoever is having the abdominal surgeries. And what is the importance of the surgical gut? So the surgical gut is going to enzyme degradation. This will be going into the enzyme degradation. I think the pen is looking so much nice. So enzyme degradation, how many days it will take? It will take the 90 days by observable sutures. That is the catgut suture. Next, we have the vicryl. So vicryl is composed with the polygalactate. This is also asked, but the vicryl is synthetic. Vicryl is synthetic, and vicryl is going to have the increased risk for infection. And how many days it will take to absorb? It will take around the 90 days for the absorb, but not the enzyme degradation. It will go under the hydrolysis. It will go under the hydrolysis that is used. Next, monofilament types. We have the two monofilament types. One is the monocryl and other one is the PDS. PDS take long time, almost 180 days it will be taking. And monocryl will be having the monocryl is commonly one question that is asked where it is used. Monocryl used in the subcuticular. This is used in the subcuticular type monocryl. And this names is important, guys. What is the composition of this? These names are also asked. Next, non-observable types. In the non-observable types, most commonly the natural type we prefer, that is the silk. Natural type we prefer is the silk, because all the skin sutures, if you see, that is all done by the skin types only, that is done by the silk only. Next, monofilament. Monofilament, we have the nylon and other one is the proline. So what is the importance of the proline that you have to take note? Proline is used for the abdominal surgeries. Proline is used for the abdominal surgeries, especially rectus sheath. Okay, especially for the rectus sheath, we will be using for the proline. And also mesh materials. Different types of the mesh materials, hernia surgeries, we will be using the proline only. Coming to the nylon, N for nylon, N for nerves. It is used for the nerves and also tendons. So high the structure, so we are going to use the nylon will be used for this patient. And also cataract can be also used this nylon type. So, okay, this is the question that can be asked in your examination. Next, blades. What is the blades that you are going to use? What is type of the blades you are going to use in the patients? Different blades will be used, right? The number that you have to remember, the number 11. Number 11. So the number 11 is used for the incision and the drainage. It is used for the incision and drainage. Number 12. Number 12 is used for the suture removal. Number 12 is used for the suture removal. Number 12 looking like a curved type. Okay. Number 10. Okay. Or the number 20. This is used for the incisions. All the other types of the incision, you can use the number 10 or the 12. This is the blades. These are the blades, how you are going to use. Next, coming to the another important points, cautery, right? So how we are going to use the cautery? So if you are in the internship, you might have seen the different types of the cautery we will be having. One is monopolar. This is the monopolar type, and other one is the bipolar type. So monopolar type, which will be consisting like a pen. Okay, bipolar, there will be two poles that will be seen. Monopolar, there is a pad that will be present. Okay, the pad will be presented. So once you attach this tip with the body with pad, so this is going to work. But in the bipolar, there is no pad. Okay, pad is not presented. It is directly from the one cautery to the body and to the another cautery. So this is how the machine will be working here. So the question is asked is where the burns can be seen. So if this pad is not attached properly, it can cause the thermal burns. Okay, so that is one seen with the burns, and here the burns are not seen. And which is going to cut and coagulate? So this can cut, and this can also coagulate, but it does not cut the structures. It is only coagulate the blood vessels. So that is the difference between the monopolar and the bipolar cautery that we are going to see, right? Next, coming to the drains, you have the different types of the drains here. This is a gastrostomy and the feeding tube, and this is a Jackson-Pratt tube. This is work by the negative pressure. This will be working with the negative pressure, and these consisting of the bulb. Another drain also you have here, you can see this is the another drain. This drain is known as a Roma vac suction drain. If you see the bulb type, that is the Jackson Pratt. If you see like this structure, that is a Roma vac. This is also works by the negative pressure only. Next, this is the mushroom tip catheter, and this is a Penrose drain, and this is a sump style tube with the sheath. This is also used for the drainage. Next, this is the open type. Okay, open rubber type. This is used for the abscesses or the pus cavities. And again, this is a Jackson Pratt. And here you can see this is a water seal tube insertion. Immediately after, whenever you see after the patient is having the the pneumothorax, we will be discussing in the pneumothorax. After doing the needle thoracostomy, you have to attach the tube, and the tube has to be immersed in the water. So, okay, so that the whatever the air that is present, it is going to suck it back. So these are the different types of the tubes that is seen. So Jackson's Pratt is used in the breast surgeries. Jackson's Pratt is used for the breast surgeries, commonly abdominal surgeries also. Romavac is more commonly used in the breast, abdomen, and also neck surgeries. It is used. Next, moving on to the total parenteral nutrition. We have the different types of the total parenteral nutrition. So in that, the total parenteral nutrition, this is only given if the patient is having more than the 3 weeks of the surgery complications is present in this patient, then we are going to use. And if ever the patient is less than 15 BMI, if the patient is less than 15 BMI, then we have to go for the total parenteral nutrition. Or more than 72 hours, the patient is having the paralytic ileus. So in this, some conditions we are going to use for the total parenteral nutrition. And what does this total parenteral nutrition will be consisting of? This consisting of the carbohydrates and proteins and the fats. How much quantity? So it is 50%, it is 20%, and the fat is 30%. Fat will be consisting of the 30%. Does it contain any other types? It will consisting of the other. For example, micronutrients is present. Okay, micronutrients is present. Next, fiber. Does it consisting of the fibers? Fiber is not consisting here. So fiber is not seen. That is only seen with the fiber is outside only. We cannot get into the total parenteral nutrition. That is not present here, right? These are the some points that you have to remember in which conditions, not just the total paralytic ileus, also we can also use for the IBD, acute IBD, Crohn's disease, ulcerative disease, severe, then we can also go for this. And if ever you see the fecal fistula, if ever you see the fecal fistula, this can be also done for the patient of the total parenteral nutrition. Total parenteral nutrition is associated, okay, total parenteral nutrition you are giving, but how you are going to give this total parenteral nutrition? You have to follow the one location, right? So the location that we are going to follow is the subclavian vein. Subclavian vein. But subclavian vein is not as safe as because it is subclavian vein is most commonly used, but it is highly associated with the pneumothorax. So the patient will be having the highly association with the pneumothorax of the patient. That is what seen with the subclavian vein, but it is very easy to accessible for us to process this condition. Next, how we are going to check the patient whether is having the good or not? So we have to keep on checking for the patient daily weight. You have to check the patient daily weight. You have to check, and also micronutrients can be checked, and also the most important one, that is the electrolytes. Electrolytes has to be checked daily in this patient. That is the one thing that you have to remember. Next, complications. Is there any complications for this having? Yes, they are the complications that can be associated. So mostly we said during the procedure itself we may have the pneumothorax in this patient, or thrombosis. If you use the other routes like femoral, the thrombosis can be seen. Air embolism can be seen, right? Air embolic can be seen while we are doing it. And infection also, over the time infection directly we are inserting into the blood, it can cause infection. And other thing, once the feeding is started, once the feeding is started, what can be seen? The patient can have the hyperglycemia, right? Hyperglycemia can be seen in this patient. Along with that, the patient can gain super weight gain because immobilized and giving so much food, that can cause. And the cholestasis, okay, liver function is disturbed, or the patient is decreased micronutrients. One of the most common is zinc, and the patient can also develop the refeeding syndrome. Refeeding syndrome also. And if ever the question is asked on the refeeding syndrome, if the phosphate is low, it can be detrimental, it can cause a congestive heart failure, and the patient can die also. That is what the refeeding syndrome is seen. Next, moving on to the blood transfusion. So before we move on to the blood transfusion, we will see the different kinds of the complications that we see after the operation of the patient. Okay, we will be seeing what are the most commonly associated complications after the patient is presentation from the surgery OT. Once we leave the patient into the ward, what are the complications will be seen? For example, if the patient is presented in the daycare surgery, if the patient is presented in the daycare surgery, what is the most common symptom? This patient will be having the nausea and vomiting. But if this patient is admitting back, if the patient is admitting back, then this is due to bleeding in the daycare surgery. Okay, that is I'm talking about the daycare surgery. But if the patient is admitted, if the patient is admitted and the patient is on our absorption only in the ward, because we cannot send the patient immediately, right? Like for example, the severe conditions, we cannot send this patient. So these conditions we are not going to the patient, but this is associated with the different types of the conditions. Let's see one by one. First, on the day one, on the day one, the patient will be having the atelectasis. The patient can be having the atelectasis, that is seen on the day one. Next, on the day two, this is commonly associated with the UTI due to the Foley's catheter, or the pneumonia, nosocomial infection like Staphylococcus aureus, or due to cannula insertion, it can cause the superficial thrombophlebitis. It can also cause the superficial thrombophlebitis. And here comes the another important point, that is the when the surgical site infection is seen on the day 4. Let's say on the day 4, surgical site infection will be seen in this patient. Okay, so this wound infection can be seen in the day 4. On the day 5, here already the patient is developed the immobilization, so the DVT can be presented in the day 5 condition. Next, day 6, this is due to burst abdomen. Burst abdomen means the sutures is not properly paced, so that can be causing the burst abdomen, and also the large type of the incision, or the patient is immunocompromised, malnourished, patient is having cough, constipation, distension. This can be also causing this condition. Next, day 7. So on the day 7, you will be having the internal abscess. Okay, this is going to be the internal abscesses in the abdomen. What is the most common site? Pouch of Dolgos. This is the most common site in the patient. If the patient is supine, this is seen in the hepatorenal pouch. You can just drain with the drainage, whatever the catheter that is present in the government settings, but in the most of the private settings they use the pigtail catheter that is used. So this is how the 1 week complications will be seen in the patient's condition. This is how the day 1 atelectasis, and the day 2 the patient is having the UTI or the pneumonia. On the day 4 is the surgical site infection, day 5 is the DVT, day 6 is the burst abdomen. How can we avoid? Actually, whenever you see the patient is having the surgical site infection, how can we avoid? We are going to avoid with the help of the antibiotic prophylaxis. Just yesterday we discussed what is the antibiotic prophylaxis. When we are going to give, we are going to give in the 60 minutes before the surgery, we are going to give for this patient. Next, transfusion, blood transfusion. So in the blood transfusion, I want to remember you guys, what is the most massive blood transfusion we call? When we call this is a massive blood transfusion. So the massive blood transfusion is called, for example, less than 24 hours or less than 1 hour. In the less than 24 hours, if you give complete, almost more than equal to 10 units is given for the patient. This can cause the one blood transfusion related complications, or within the 1 hour you have given the more than 4 units. Okay, within the 4 units is given for this patient. This is next. What happens? What is the complications that will be seen with this patient? So we are actually giving the citrate stored. So this citrate can chelate the calcium, so calcium will be decreased in this patient. Next, another thing is the increased potassium. Why increased potassium? Because stored bloods will be lysed. Some of the bloods will be lysed. That can cause the hyperkalemia in this patient. Next, hypomagnesium and decreased temperature. And along with that, you will be also seeing the metabolic alkalosis. This is known as a lethal triad. So this is known as a lethal triad. What happens in this lethal triad? So the patient can likely to develop the coagulopathy. So this is going to be the most common cause for the death in the massive transfusion. This is the most common cause for the massive transfusion of the patient. Next, another condition, that is the TRALI. So this is the TRALI condition. So what is mean by the TRALI? Transfusion related acute lung injury. How the acute lung injury is happened? Most commonly after the general transfusion. Okay, I'm not talking about the massive transfusion. This is about the general transfusion. You have given the 1 unit of the blood. So in the patient, what happens? This 1 unit of the blood. So this have the HLA antigens already. So HLA antigens is presented. So these HLA antigens are fighted with the antibodies. This will be fighted with the antibodies. That antibodies is going to cause the pulmonary reaction. Once this pulmonary reaction is going to see, so the patient will be developing of the edema. So the condition will be ARDS, but this is a non-cardiogenic, right? This is due to internal inflammation due to antigens and the antibodies inflammation, right? So this is when this is going to occur less than 6 hours of the transfusion, not the massive transfusion. Don't confuse with the massive transfusion. This is just 1 to 2 units of the transfusion can also be seen here. Next, another reactions. Another complications is taco. Another complication is taco and febrile related. So TACO means this is a transfusion associated cardiac overload. So the patient can develop the congestive heart failure that can be seen in this patient. Febrile related is mostly due to leukocytes. Febrile related is mostly due to leukocytes. So this is going to cause the febrile illness. So what we can do, you can do the without the leukocytes, you have to give the transfusion for this patient, right? So this is how the transfusion and related complications that you have to remember. Next, moving on to the breast surgery. In the breast surgery, you have to take note whenever you see the patients with the breast surgery, breast lesions. First and foremost, as a general surgeon, we are going to follow the physical examination and focused examination of the clinical examination of the patient. In the clinical examination, we are going to use the breast examination. The best method is a dial clock method. That means circular method that you are going to follow. Along with that, you are going to see if there is a lesion, you are going to go for the radiology. And if you want to more if you want to have the workup, then we can go for the biopsy. So this is known as a triple assessment, right? This is known as a triple assessment of the breast lesions. And in the radiology section, if the patient is less than 40 years or if the patient is more than 40 years. So if the patient is less than 40 years, go for the ultrasound, or if needed, MRI can be done for this patient. But if the patient is more 40 years, then we can go for the mammogram. Why we are not using the mammogram in the less than 40 years? Because the dense breast cannot be differentiated in the mammogram in the less than 40 years. Next, we have the different types of the lesions, guys. We have the different types of the lesions is presented here, if you can observe. So this is the types of the cyst, type 1 cyst and the type 2 cyst, and other types are the papilloma and the ductal hyperplasia and the sclerosing adenosis, fibrocystic disease and the fibroadenoma, right? Simple cyst can be the most of the times the patients, those who are presented with the simple cyst, it can be treated as per the age group or as per the symptoms they presented. Most of the time simple cysts are due to estrogen only. So by the menstrual cycle, that will be regressed or that will be increased. Next, we'll be differentiating between the fibrocystic and the fibroadenoma. Fibrocystic is benign. Okay, remember, fibrocystic is benign, and always this fibrocystic is associated with the cyclical changes. Cyclical changes means menstrual changes. These are the important and this patient will be having the mastalgia. Only the pain will be seen in this patient, and no treatment is needed and no malignancy progression. No malignancy progression. So simple, the patient can having these changes, and that will be decreased after the menopause. If after the pregnancy also some patients will be decreased, so the supportive treatment will be given. Next, fibroadenoma. This is also benign condition and most common benign condition. This is also associated with the cyclical changes. Okay, cyclical changes and movable, and we can say firm and symmetrical. There is no irregular borders that will be seen. And the treatment is what we can do is, if the patient is having the lesion is increasing, okay, the lump is increasing, or the patient is having the more than 5 centimeters or the cosmetic issues, then we can remove. That is, lumpectomy can be done for this patient. Other than that, it is always supportive treatment only. Supportive treatment only. On the chest mammogram, on the mammogram, you're going to see the popcorn classification. Popcorn calcifications is seen. This is for the fibroadenoma, which is also known as a mouse type. Next, we will be discussing of the coming to the cancer. In the cancer, the first and foremost important topic is the Biret scoring. So this is known as a Biret scoring. Biret is done with the using of the ultrasound. This is used with the ultrasound, and in the Birets we are going to check for the imaging report that is given as a 6 categories. Okay, so 0, 1, 2, 3, 4, 5, 6. This is the 6 categories. 0 you can forget because most of the times 0 is not asked. You have to remember only 6. So first is negative. This is a routine screening, especially 0% of the people. So you can just tell the patient to follow up after the 1 year if the risk factors is present. Second one is a benign lesion. This is also especially there is no malignancy risk. This patient can also follow up after the 1 year. Third one is probably benign. We will tell the patient to follow up after the 6 months. We will tell the patient to follow up after the 6 months. So 1 and 2 is for the 1 year. Third one is for the 6 months. Next, fourth month, we are actually suspecting some of the lesions that can be malignancy potential. So 4A is a low risk, 4B is a moderate risk, 4C is the high risk for the malignancy. So what we will tell? We will tell the patient to go for the biopsy as a safe side. Fourth is for the biopsy. And fifth is highly malignancy suggestion. We always tell the patient to go for the biopsy. And sixth is non-biopsy proven. The patient is already biopsy proven. So the only ultimate treatment is the surgical option we have to take for the patient. That is the first thing that you have to remember for the patient. Right? Then how we are actually suggest the patient to go for the screening, because most of the patient, even if there is a lump is present, they are not going to present it. Then how we are going to suggest this patient? Only we can suggest this patient by using their risk factors. On average, every female is have the risk of breast cancer with age, right? This is the first factor. So if with the age factor, what we can tell, after the 40 years, after the 40 years, they can go for the annual screening. They can go for the annual screening. This is most commonly used in the Western countries, right? Next, another is if they are presented with a risk factor. For example, they are presented with the BRCA1 mutation, which is high risk. So this is the 17th chromosome, or the patient with the BRCA2 mutation. This is present with the 13th chromosome, and this is equal risk for the male and female. So for these individuals, usually we will recommend them to go for the 25 years only. So if the patient is more than or equal to 25 years, they can go for the annual screening. They can go for the annual screening every year. And first line is MRI only as soon as possible, because as I said, mammogram is highly dense tissue, cannot be seen. Next, if the BRCA mutation is not seen in this patient, what can be? Because of the relative history, sister or the mother, grandmother, if there is a close relative risk, so these patients can also go. Okay, or the strong medical history, ovarian cancer, pancreatic cancer in the family, or any other cancers, okay, significantly passing. So these patients can go after 35 years. This patient go for the after 35 years, and 35 years also MRI we will be choosing. So this is how these patients can go for the annual screening. So this is the protocol that can follow for the patients. Next, coming to the breast cancer. So breast cancer is regardless of the gender. This is has been showing the significant increasing incidence. For example, females are more common with comparing to the males, but males are not less. Males are also associated, and increased age, and also social activities like smoking or the alcohol. Okay, smoking and alcohol, obesity, and chronic depression sometimes can cause. Coming to the gynecological, the patient is having the early menarche or late menopause in the patient is having the late menopause, or nulliparity, they had never had the nulliparity, or patient is have the risk factor previously with the history of the radiation. This can be caused, and no breastfeeding has been done by the patient. And family history, genetics play the major role. Okay, family history, okay, relatives, mother, any side, or the patient is taking the hormone replacement therapy, especially high estrogen and progesterone, right? And patient is has given the first birth more than 30 years. This is also risk factor, but less likely. Next, what is the most common type that you are going to see? So the most common type of the cancer is invasive ductal cancer. This is an invasive ductal carcinoma. And where is the most common location? Upper quadrant, upper outer quadrant. For example, this is the breast, right? So here is the lesion. So this is the inner, sorry, this is the inner, outer, outer. So this is the outer quadrant, upper quadrant. So this is the most common site. This is the most common site we are going to see in the patient. So this is the ductal carcinoma. This is the invasive ductal carcinoma that will be presented in the patient. Lobular carcinoma is no more considered as a carcinoma. Okay. This is a potential to progress to the cancer, but mostly it is a not a cancer. It is just a cancerous lesion. It can progress to the malignancy. And how we are going to subclassify this cancers with the using of the molecular subtypes, with the using of the immunochemistry and the molecular subtypes. Luminal A, which is considered as a ER positive and the PR positive, and the Ki767 is positive but low levels. Okay, this is a low levels. Luminal B, the Ki67 is highly positive with the ER positive and the PR positive. Okay, that is with the luminal B, and most of the times this is known as a triple positive. This is known as a triple positive. Next, HER2 enriched. It is only positive for the HER2 only. Only it is positive for the HER2. Next, normal like lesion. Normal like lesion means it is only hormonal type. Next, basal like. Basal like is the triple negative, and this has the worst prognosis. Worst prognosis is seen with the basal type, and the more even dangerous thing is it is even seen with the young patients. This is seen with the young patient, and young patients is also associated with the basal type. The best prognosis is luminal A. This is the best prognosis, and the worst prognosis is the whoever is presented with the basal like or the triple negative breast cancer presentation, right? Next, the important thing that you have to take note about here is the tumor staging. This is about tumor staging. Okay, in the tumor staging we will be following this classification, guys. You can remember this way. For example, T1, T2, T3 and T4. Okay, mnemonic you have to remember is the cure mnemonic. What is the cure mnemonic? I will tell in a while. So T2, just remember T2 for 2 centimeters, 2 to 5 centimeters. That means above the T1 less than 2 centimeters, below the T2 that is more than 5 centimeters, right? Next, T4, that means already it is more than 5 centimeters. I mean inside the structures is involving. So C for chest wall involvement. C for chest wall involvement, that is C4A. This is C4A. 4AC. 4A. This is the 4A. This is the mnemonic cure. Next, 4B. This is ulceration, means it is involved the skin and lymphatics. If it is lymphatics is involved, they're going to present with the body orange appearances. Next, R for A and B. This is the 4C. Both 4A plus 4B has to be required for the 4C. Next, 4D. This is the 4D. Remember, like inflammatory. Okay, inflammatory means inflammatory type. More than one third is going to cause the inflammation. Then that is the 4D type. This is the tumor staging for the T staging. Next, coming to the N staging. N1, N2, N3. N3. N1 for the one lymph node, most commonly axillary is the first one to involve, and this is movable. Next, 2 for two lymph nodes will be including. Let's say 2A, that means axillary lymph node, and this is fixed. 2B, this is the internal mammary lymph node, and N3 is A, N3A, N3B, N3C. So three nodes is involved. So one is One is going to be the infraclavicular, infraclavicular, and this is a supraclavicular. And here we have 2A plus 2B, that is for the 3B of lymph node involvement. This is the tumor staging that you have to remember for the important points of our examination, right? Next, can it cause the metastasis? Yes, it going to cause the metastasis. Most common location is the bone. This is the most common. And how it is going to cause? Through the lumbar venous supply. And what is that supply? That is the Batson's plexus. So the most common location is also lumbar. And how? This is the bone lytic lesions. Bone lytic, then the blastic. It can be both also, but the most common is the lytic types. Next, how is the treatment is given for this patient? What is the treatment of the choice that we are going to follow for this patient? So before we go for the last points of the treatment, I want you guys to understand about the important points related to the breast surgery. So if ever the treatment is given for the patients with the breast lump, especially, that is the first and foremost is the lumpectomy. Lumpectomy is done for this patient, which is also known as a breast conservate surgery, but always it has to be followed by the radiotherapy. Always this has to be followed by the radiotherapy that should be given to prevent the patients from the local recurrences. This is the one of the surgery, that is a lumpectomy, breast preserving therapy. Next, other one is the mastectomy. Other one is the mastectomy. In the mastectomy, we will be following of the radical type. Radical type. Here we will be removing of the breast and lymph nodes. At least 4 lymph nodes will be removed. Okay, 3 to 4 lymph nodes is removed, and also pectoralis muscles will be removed. Pectoralis major and also minor, both will be removed in the radical mastectomy. In the modified radical mastectomy, major is not removed. In the simple mastectomy, no lymph nodes is removed. That is the one thing that you have to remember. Okay, simple is only the breast is removed. Lymph nodes are preserved, it is not removed. That is the first thing that you have to remember. Next, complications related to the surgery. Any surgery, the most common complication will be hemorrhage. Okay, hemorrhage will be seen. And if ever the nerves are involved, the most common nerve that will be included is the intercostal nerve. Intercostal nerve that is involved in this patient, and also long thoracic nerve. Long thoracic nerve is involved. So this is the second most common, is a long thoracic nerve. And the late presentation is the lymphadenoma. Lymphedema. Lymphedema will be seen in this patient. Late time of the recurrences will be seen. And the other will be also seroma. Seroma can be acute also, right? Seroma formation can be acute also. Late is the lymphadenoma is seen in this patient. Next, flaps we use. Flaps, this is for the reconstruction, especially for the cosmetic purposes, reconstructive surgeries. Okay, we use the latissimus dorsi, or we can use the rectus abdominis also. The best is the deep inferior epigastric, because this is also consisting of the artery. Okay, and also complications will be decreased. This is the best, deep inferior epigastric, and also second best is the latissimus dorsi, we can use for the breast reconservation therapy. Next, we also have the other therapy. What is neoadjuvant therapy? Neoadjuvant therapy, that means we give the chemotherapy for the patient, and then we'll go for the surgery. Then followed by, most of the times, sometimes it can be given the radiotherapy or chemotherapy. So this is plus or minus. So in which patients we will be following the neoadjuvant therapy? Which patients we have to give the neoadjuvant therapy? Neoadjuvant therapy can be given if ever the patient is having the lymph node involvement, or the patient is having the locally aggressive tumor involvement is presented, and hormonal is not presented, ERPR is not positive for this patient, and only HER2 is positive. this patient only we will be following the neoadjuvant therapy. And which patients are contraindicated for the neoadjuvant therapy? If ever the patient is in the T1, T2 stages, we are not going to give, and if the patient is HER2 negative, also we are not going to give for this patient, right? This is how neoadjuvant therapy is given for this patient. Next, coming to the hormonal, that is ER positive and also PR positive. For this patient, what is the drugs that can be given? So one is the SEM drugs. The SEM drugs, that is a common one, is the tamoxifen. Tamoxifen is given for this patient. Other one is the letrozole. This is the aromatase inhibitor. This can be also given for this patient. But highly, the most of these drugs, if ever the patient is taking these drugs, we have to be cautious for the giving for this patient. Why? Because this will be having the side effects. These side effects can be most detrimental also. For example, let's take tamoxifen. What happens if the patient is taking the tamoxifen therapy? So the patients will be having the associated with the endometrial hyperplasia that will be seen with the tamoxifen. For the letrozole, the patient can develop the osteoporosis. This will be seen. Next, other drugs also presented. We can give the doxorubicin. We can also give the doxorubicin. Anthracyclines can be given for this patient. And also the best drug, the HER2 positive. If the patient is HER2 positive, for this patient, we going to give the trastuzumab. Trastuzumab. But this is highly associated with the cardiotoxicity. This will be highly associated with the cardiotoxicity. And CDK4 or 6 positive, for this patient we will be giving the palbociclib. Palbociclib. This can be also given for this patient, right? These are the some of the drugs that we are going to use for the patients of the breast cancer. These are the important points that you have to remember. For example, if you see the patient is presented with the, let's say the patient is pregnancy patient, what you can do, you can go for this surgery. So breast cancer patients, you can go for the breast conservating surgery. But can I give the radiotherapy? You cannot give the radiotherapy. You have to give after the patient is came after the pregnancy. We have to give the patient with radiotherapy. Next, coming to the breast abscesses. Breast abscesses is most commonly associated with the lactational. Okay, lactational is the most common, especially if the baby infant crack that is seen in the nipple region. This can develop the breast cancer. Sorry, breast abscesses. What is the most common organism, guys? The most common organism is the Staph aureus. Staph aureus is the most common type. So if the patient is developed with these kind of abscesses, so the patient can continue the breastfeeding. Yes, the patient can continue. And what is the drug of the choice for the treatment? Amoxiclav. Amoxiclav is given for this patient. But here you can see the patient is having the severe abscesses, fluctuant mass that is seen in this patient. So for these patients, here you can see for these two patients, what we can do is the ultrasound guided aspiration is done. If this is also fail, then we can go for the incision and drainage with antibiotics. Incision and drainage with the antibiotics that can be given for this patient. Next, another condition that you have to remember is the phyllodes tumor. That is the phyllodes tumor. So phyllodes tumor is mostly benign condition, but this phyllodes tumor is actually rapid and most enlarged tumor. This is the most enlarged tumor. This is the rapid and most enlarged tumor. And if ever it is metastasis, is mostly not going to spread to the malignancy. But if it is going to malignancy development, it can cause the lung metastasis. Lung mets is seen. It is not going to cause the bone. It is going to cause the lung metastasis. So phyllodes tumor, how can be the treatment is done? Simple. It can be done simple mastectomy, or we can go for the lumpectomy, breast conservating surgery. But most of the times simple mastectomy, because of it increased growth, we are seeing that it has to be treated. That is a one point that you have to remember, right? These are the important points of the breast surgery that you have to remember, guys. Next, moving on to the thyroid surgery. Thyroid surgery. In the thyroid, we will be discussing first and foremost important is the thyroid scan. In the thyroid scan, how we are going to visualize. So here you can see thyroid scan. The most commonly used thyroid scan is the iodine 123. This is used is the iodine 123 is used for the patients. So if you see the cold nodule, this kind of the cold nodule is associated with the severe tumor increase. The risk is more with the cold nodules. When it is compared to the hot nodules, here you can see this is the hot nodule, more functioning, right? So this is a solitary type. This is a solitary type, but malignancy risk is 4% only. When it is compared to here, it is 20% and here it is 4%. Next, Graves disease, it is a diffuse pattern that you are going to see. Toxic nodule, like abnormal, okay, this is a how abnormal multiple hot and cold will be seen. And thyroiditis, it is already completely inflamed, so the destruction is happened and it is not going to show the any kind of diffuse pattern is seen. And autonomous nodule, suppression of the remaining nodule that is seen with the patients. Next, Bethesda classification. Bethesda classification is we are going to get at a time what is the category, what is the treatment. This is the old pattern that we will use, Bethesda classification, and it is similar to the FNAC. It is similar to the FNAC. Both are same only. How we are going to see? So same as we have the 6, we are also here also we will be having the 6 types. FNAC is having the 5 types only, but here it is a 6 types. How we are going to see? So first one is a non-diagnostic. We are not going to do anything. We just have to repeat the FNAC guidance. And 2 is a benign condition. That means it is a non-neoplastic. We will just the patient to the follow-up only. Next, 3 is going to be the non-neoplastic again, and but this patient has to get the repeat the FNAC and has to be done. And the fourth one is a follicular type. The fourth one is a follicular type, and here you have to do the lobectomy. And if in the FNAC it will tell hemithyroidectomy has to be done. This is the recent INICT question. The patient is presented with the FNAC grade 4 that is presented. What has to be done for this patient? Hemithyroidectomy according to the Bethesda. But in the FNAC, this is the third stage. This is the third stage in the FNAC. In the Bethesda, it is a fourth stage. Okay, and the fifth and the sixth is highly malignant. The patient has to go for the surgery. Highly malignancy suspicion. The third is the follicular carcinoma. That is the one thing that you have to remember. Next, another condition. Here you can see this patient is suffering from the thyroglossal cyst. Thyroglossal cyst. What is the meaning of the thyroglossal cyst? The patient has developed this cyst since congenital condition. The tract, for example, we will be having the tract here. So the tract can be developed as a thyroid gland. So some patients, what happens, this tract is not got. So this persistence of the tract that is going to develop as a thyroglossal cyst. And where is the common location? So this is the hyoid bone, right? So most of the times, so this is how the hyoid bone will be presented. So this will be below the hyoid bone. So subhyoid is a common location, most common location. And with the patient is protruding tongue or the deglutition, it will move. So it will move with protrusion of the tongue. This is the classical that you are going to see in this patient. But some patients can develop the papillary thyroid carcinoma, some patient can develop the sinus, some patients can develop the fistula also. So to avoid this, we can just remove this with the using of the cyst trunk procedure. Cyst trunk procedure. So in the cyst trunk procedure, we can remove this. How we are going to remove? Remove the tract. Okay, up to the base of the tongue. So the base of the tongue can be also removed a little bit, and also hyoid bone. So hyoid bone part, not the whole hyoid bone, only just small part, whichever the tract is included, we can go for the hyoid bone tract removal also in the cyst trunk procedure. All right, next we will be discussing of the different types of the surgeries. The most common is the total thyroidectomy. The most common is the total thyroidectomy. In these patients, whoever is go under the total thyroidectomy, same risk factors will be presented with any other also. So what is the incision that is done here in the patients of total thyroidectomy? This is the collar incision. This is done the collar incision. And what is the position? The position is the rose position. Okay, two important points is done. Then complications. What is the most common nerve? What is the most common nerve? That is the external laryngeal nerve that is most commonly involved, right? Next, what is the most common post-operative? Post-operative, the patient is having the respiratory distress. This respiratory distress is actually due to laryngeal edema, not due to nerve injury, but because of the laryngeal edema. That is also seen. Next, what is the late complication? The late complication is patient will be having the hypoparathyroidism. It could be accidental removal or it could be due to vascular ischemia. That is also seen. Any of these conditions can be presented with the patient of the hypoparathyroidism as a late manifestation in the patients. Okay, that is the one thing that you have to remember. Next, moving on to the different types of the cancers. One is papillary thyroid cancer. So these papillary thyroid cancer, it can be associated with the radiation, and it can be associated with, just now we discussed, thyroglossal cyst. Thyroglossal cyst can be seen, right? This is the one of the cause, and it is mostly associated with the females, then the males, and also with the age. And the genetic associations here is the BRAF gene. BRAF gene is most common, then P53. Then we also have the APC gene that is also involved here in the PTC, papillary thyroid carcinoma. Next, spread. How it is spreaded? With the route of lymphatic spread. It will choose the lymphatic spread to induce the metastasis. That is going to be seen here in the lymphatic. And what is the most common site? The most common site is the lungs. And what is the positive for this? Thyroglobulin is the marker that is positive in these patients. Thyroglobulin is positive. Next, on the biopsy, you are going to see the classical appearance of the somoma bodies. Somoma bodies will be seen in this patient, right? Somoma bodies is seen in this patient. Along with that, orphan nuclei. Orphan nuclei is also seen in this patient. That is what papillary thyroid carcinoma is seen. Next, follicular thyroid carcinoma. This is the second most common. This is the second most common, and it is also associated with the goiter. Whoever is having the goiter is having the risk. Females are more common than the males, and this is the associated genes are Cowden syndrome and also Werner syndrome, not the Wermer. Wermer is different. This is Werner syndrome. Next, the patient will be having the spread through hematogenous. So the spread is due to hematogenous. So hematogenous, so you have to remember, if it is a hematogenous, the most common site will be bones. Okay, the difference you can notice. Lymphatic is lungs and the hematogenous is the bones for this patient, right? Next treatment we just now discussed, Bethesda method, that is direct hemithyroidectomy. Hemithyroidectomy has to be done for this patient. And one point that you have to remember is there is a association which will be seen with the Hurthle cell type, Hurthle cell carcinoma. Hurthle cell carcinoma, this is more aggressive and worst prognosis with the follicular thyroid carcinoma. Next, medullary thyroid carcinoma. Medullary thyroid carcinoma, which is mostly associated with the genetic type, and this is not associated with the any of the common roots, okay, because it is originated from the parafollicular cells. It is originated from the parafollicular cells, C cells. So, and it will be associated with the amyloid stroma, and here also thyroglobulin is positive. So this patient also thyroglobulin is positive. But in the medullary thyroid carcinoma, it is not thyroglobulin, rather than it is positive for the calcitonin. And genes that is involved here is the red gene and also MEN syndromes. We will be discussing the MEN syndromes in a while. So MEN syndromes is also involved in these patients. That is the one thing that is associated with this medullary thyroid carcinoma. And the last but not the least, that is the anaplastic. Okay, anaplastic. This anaplastic is rare, but it is worst prognosis. Okay, complete worst prognosis. This can produce the lung mets. Early staging will be seen, like severe staging will be seen, older individuals, and very worst prognosis will be seen in these patients. Right? These are the types of the cancers that you have to remember. Next, MEN syndromes that I want to mention here. Let's see MEN1. MEN1 is also known as a Werner. There I said Werner. This is the Werner. MEN syndrome, which will be remembered as the PPP. One is the pituitary tumor, and other one is the parathyroid tumor, and here it is pancreatic tumor. Next, men2 this is the Sippel syndrome. And here it is associated with the medullary thyroid carcinoma and also other parathyroid conditions and pheochromocytoma. Next, men3 which will be associated with the EMS. Okay, EMS. So this can be associated with the megacolon, morphonoid features, and medullary thyroid carcinoma again, and also mucosal neuromas. And men3 is also known as a 2B. Next, men4. Men4 remember as a trap. So one is testicular, other one is a renal tumors, and other one is a adrenal tumors, and again back to pituitary. So these are the MEN syndromes and associated diseases. Next, let's see some of the miscellaneous topics. Okay, like here you can see this is the retrosternal tumor. And what is the sign that we are seeing here? This sign is known as a Pemberton sign. So if the thoracic inlet is involved, so the patient will be having a sudden of the flushing, that is seen with the Pemberton sign, that is seen in this type of the conditions. So retrosternal tumor, if ever it is presented, we can just remove, but if the patient is having the severe, then we have to go for the sternotomy. We have to remove the sternum and then we have to do the surgery. Next, coming to the oral lesions. Let's see the oral lesions. So in the oral lesions, this is the normal tongue. If the patient ever is having the candidiasis, this is how the fungus infection will be seen. And the lesions that you have to remember is the leukoplakia. This is associated with the EBV, Epstein-Barr virus, and also it is associated with the malignancy. Okay, malignancy will be seen. This is the strawberry tongue, which is seen with the infections. And hairy cell leukemia, this is associated with the leukoplakia. Lichen planus, this is autoimmune condition. This is a pemphigus vulgaris blisters is seen. Hairy tongue, it could be due to genetics, and fissure tongue due to the nutrient deficiency. Atrophic glossitis due to dehydration. Geographic tongue, it is also due to autoimmune conditions. But leukoplakia, opposite to that, you're also having the erythroplakia. And this is erythroplakia is also associated with the malignancy is seen, but 2 times more comparing to here. If it is 5%, it is 20%, 2 times more the risk will be seen with these conditions. What is the most common type is the squamous type. Okay, most common location in India, it is gingival sulcus in India, whereas in world it is lateral. In the world, it is the lateral wall that is associated with these tongue lesions. Okay, that is the one thing that you have to remember. And if ever the patient is having these conditions, what we can do, we have to just remove the wide local excision that has to be done for this patient, right? Next, coming to the some of the salivary gland abnormalities. Salivary gland abnormalities we will be seeing. So this condition is known as a ranula, right? Ranula. What is happening in the ranula? So the mucus is keep on loading at one space, that is a sublingual node, sublingual gland. This sublingual gland, which will be extravasation of the cyst. And what is the location? Floor is the most common location for the patient. And what is the treatment? Simply you can just marsupialization can be done, or you can just remove the cyst, and also sublingual gland can be also removed for this patient. That is the treatment that we can do. Next, this is the salivary gland stones, mostly associated with the calcium phosphate. This is associated with the calcium phosphate. Investigation of the choice is the NCCT, and treatment for this patient is the endoscopic removal. And which gland is most commonly involved? So the gland that is most commonly involved is the submandibular. Submandibular gland is involved in this patient. Next, here comes the important tumor, that is the pleomorphic tumor, or we can say this is the pleomorphic adenoma. So if you, before we know about the pleomorphic adenoma, whenever the salivary glands is seen, so the benign conditions is most commonly involves the parotid gland, and the most common tumor is the pleomorphic type. Next, second most common, that is malignancy. Malignancy will be involving the sublingual or the minor glands, sublingual or the minor glands that is seen, and in the sublingual glands we will be seeing the most common other type, the tumor will be is the carcinoma, which will be associated with the adenoid type. If ever it is involving the, this is the benign, if ever it is involving only the parotid, then the malignancy that is most commonly associated is the mucoepidermoid carcinoma. This is the malignancy in the parotids. So pleomorphic adenoma, most commonly this is unilateral. This is most commonly unilateral, and mass that can even includes the lobule of the ear also involved in this patients, and sometimes deep lobe is also involved, and but this is only superficial, and it has a very best prognosis of overall all the tumors, and rarely it can produce to the patients to the condition of the malignancy. This is painless condition also. On the biopsy you will be seeing the triphasic pattern, that means stroma, epithelium is involved, stroma is involved, and also myothelium. Myo is also involved in this patient. That is a triphasic pattern. What is the treatment? Simply excision has to be done for this patient. If ever the lymph nodes is involved, then we have to go for the radical neck dissection is done. Next, we have the complications associated. What is the most common nerve that is involved? So the most commonly the nerve is involved is the greater auricular nerve. So the patient will be having the breast, this is the beard location, no sensation, okay, anesthesia will be seen most commonly. Next, another nerve that is we all know that could be facial nerve or it could be marginal mandibular nerve. Next, Frey syndrome. What is the Frey syndrome? Frey syndrome is involving of the other nerve, that is nerve of the auriculotemporal nerve. Auriculotemporal nerve. So how can you remember, guys? Because it is a quite confusing, and most of the time people will be making of the mistakes. So greater auricular nerve, that is going to involve the beard location. So you just remember, whoever have the beard, they will be feeling of the greatest achievements. Okay, one that you can remember. And Frey syndrome, this is actually going to increase the parasympathetic activity. When the parasympathetic activity is increased, so this is going to cause the sweating. This is going to cause the sweating that is associated with the food. So this is, here you can see, this is the patient. Okay, he had the surgery. Here you can see, this is the surgery incision, and when the patient is taking the food, he is having this gustatory sweating that is seen in this patient. So this is known as a Frey syndrome, involving of the auriculotemporal region. So how can you remember? Frey is a person. He went to the ATM, auriculotemporal nerve. Just remember this as a ATM. When he went to the ATM, he has this sweating. That's how you can remember. And what is the investigation of the choice? Investigation of this choice is a starch iodide. When you give the starch iodide, it is going to be positive in this patient. Treatment of the choice is tympanic neurectomy. You can just cut the neurectomy at this location. At this location, you can cut that now. So let's discuss the another important topic, guys. That is the trauma. Okay, trauma is most probably, at least two questions can be expected. It could be related and integrated with the radiology. It could be integrated with the multiple systems. It could be directly from the trauma basics itself. So trauma and the burns topic is very important for our topics. So let's start with the shock. So shock is having the different types of the shock. It could be hemorrhagic, which is the most common, hypovolemic shock, or it could be cardiogenic, obstructive, or the distributive shock. So how we are going to find out that the patient is having the shock? So the three symptoms that you have to remember for the shock is the quick SOFA score that you have to remember. So first is the patient is having the hypotension, which is less than 100 mmHg. Next, altered sensorium, and also tachypnea, means increased respiratory rate, that is a 22 per minute, that is increased. So if ever the patient is having more than 2, that criteria is considered as a poor outcome in the patient. Next, we also have the shock index. So the types of the shock index is, one is the shock index and other one is the revise. Revise is the most sensitive. This is the most sensitive, and shock index is most commonly performed. So what is the shock index, guys? Heart rate by the SBP, systolic BP, and revised is the heart rate by mean arterial pressure. So these are the two important findings that you have to correlate with your physical examination findings. Next, let's see types of the shocks and how to identify. So hypovolemia shock. So hypovolemia shock is the fluid loss from the body. It could be diarrhea also, it could be also blood loss. So most commonly with the trauma patients, like blood loss, or the patients with the fluid loss in the burns or the diarrhea patients. So hypovolemic shock, the patients will be having the decreased BP and increased heart rate. So this is the classical finding that the presented in the hypovolemia shock. So central venous pressure will be low, systemic vascular resistance will be high, and the extremities will be cool and clampy. And what is the treatment that you have to give? If there is a blood loss, blood transfusion should be done, and the fluid should be given for this patient. Next, cardiogenic shock. Cardiogenic shock will be mostly associated with the MI and also the arrhythmias. In the cardiogenic shock, so the patients with the central venous pressure will be increased, and the systemic vascular resistance will be also increased here. So this patient, the BP will be increased, and also this patient's heart rate is also increased here. In this patient, the both are increased in the cardiogenic shock. How you are going to treat? Revascularization. Whatever the underlying cause, you have to treat that cause. Next, obstruction shock. Obstruction shock is could be peripheral, sorry, pulmonary embolism or the cardiac tamponade. For this patient, the heart rate will be decreased, muffled heart sounds, and also decreased BP, which will be seen with the obstructive shock. And for this patient, we have to relieve the obstruction. That is the first thing that you have to remember. Next, distributive shock. Distributive shock, the patients will be having the vasodilation, could be associated with the sepsis or the anaphylaxis due to the histamine release. And here, these patients will be also having the increased heart rate and decreased blood pressure will be seen. And also, most of the times, how you are going to identify the shock in this shock in the any of the the clinical indicator that you have to look if the urine output is normalized or the urine output is decreasing. So that is the clinical indicator that we are going to check in the every shock patient. And whatever the treatment is, mostly give the IV fluids and look after for the any severe signs in these patients. Next, coming to the burns. In the burns topic, the most important thing that you have to remember is the burns classifications. So here you can see, so this is how the classification was done. Superficial, which will be only limited to the epidermis, partial thickness, which will be including the dermis, and full thickness, even the muscle and the subcutaneous tissue also seen in this patient. So the first degree burn is only affects the epidermis, and it is so painful. Okay, this is so painful condition. Next, partial thickness is a second degree burn, which will be including the part of the dermis, and this is also very painful, and it takes at least 2 to 3 weeks. And if it is involved whole dermis, if it involves the whole dermis, just now we will be seeing in the next one, that is a full thickness or the third degree burn, so it is painless. So the point to differentiate the third type of the burn, that is painless because of the nerve is also damaged. So nerve endings, the nerves that is damaged, which will be seen in the full thickness burns. Next, so the formula that we are going to use is the total body surface area valley score that we are going to take. Right, in the valley score that you have to remember, at least for adult, most of the times in the previous examinations, if you see, most of the times it is asked on the adult patients only. So remember the adult patients 9 of the score, how you are going to calculate. So anterior and the posterior of the head, which will be 9%, neck is 1%, and front body and the back body, if you combine, that is a, this is a chest. Okay, only the front chest and the front chest and the back side, that is a 80%, and abdomen, front is 9%, back is the another 9%, and 4.5 and the anterior, 4.5 on the posterior for the both the hands. So that means arms will be 9%, and 1% is for the anal area, and 18% for the one limb, lower limb, and another 18% for the another lower limb. Next, what is the fluids of the choice that you are going to give? So whatever the fluid that is available, you have to give for this patient to avoid the patient condition from the hypovolemia shock. Most of the times we will be preferring the RL. And how you are going to calculate that formula? Use the formula of the 4 ml into the body weight into total body surface area is burned. So nowadays the protocol is completely following the 4% only. Okay, so the 4% that you have to follow, and after calculating, the half of the fluid is given for the first 8 hours and remaining fluid is given for the next 16 hours, and most of the time ringer lactate is preferred. So if the patient is died immediately, the cause is due to inhalational injury, and if it is an early cause more than 24 hours, it is due to fluid loss hypovolemia shock. If it is a late more than 72 hours, that is due to septic shock due to pseudomonas organism. Next, what is the treatment? Other treatments that we can give, such as antibiotics, silver sulfadoxine. This ointment is given. This is works as an ointment and also to kill the pseudomonas sepsis also. Next, coming to the trauma, main trauma, we have the primary trauma and secondary trauma surveys. So primary survey, which will be including of the A, B, C, D, E. A for airway, and B for breathing, C for circulation, D for disability, and E for exposure. Okay, and another picture that you can see here, what is this procedure that they are doing here, guys? This is a circothyroidotomy. Circothyroidotomy. So why this circothyroidotomy is important? For example, the most of the times we are going to do the ET intubation immediately to save the airway. If ET intubation is failing, then we have to go for the circothyroidotomy. Ultimately, you are going to do the tracheostomy only. But if you want to save this patient from the airway disturbances, you have to do this circothyroidotomy. So the best one is a scalpel rather than for the needle. That is the one thing that you have to remember. Next, coming to the secondary survey, we are actually getting to know about the patient history. Does he have any allergies? Is he taking any medications, for example warfarin or the heparin, or is the patient on any medications, or the patient have any past medical history, like patient is on the diabetes mellitus, epilepsy patient, or the last meal to avoid the aspiration. All this we will be looking for the patient, and also surroundings where the patient is had. Is he injury at the bridge, or it's a patient is injury at the seashore? So these things also we have to take the consideration. So first and foremost important thing is the patient. If ever the patient is died on the spot, for example, let's say the patient is died at the spot within the minutes, that is due to most commonly head injury only. So we have to evaluate the head injury in this patient. The most common types of the head injuries are subdural, and other type is the epidural hematomas. So epidural hematoma is between the skull and the dura mater. Epidural hematoma is between the skull and the dura mater. Subdural hematoma is between the dura mater and the arachnoid mater. So what is the difference between? So skull and the dura mater, you have the sutures in between. You have the sutures in between. So if ever the hematoma is formed here, it is does not going to cross the suture lines. That is the first identity for you guys. And this is going to associated with the middle meningeal artery. So the blood is very flush, that is coming from the directly from the aortic circulation. So this is going to cause the severe distress in the patient. So intracranial pressure will be increased, and more this is going to spread within the sutures. Okay, once they are spreading within the sutures, it does not cross the sutures, but it can push the brain. So the midline shift is seen clearly in the epidural hematoma. Okay, ultimately the patient will be having the craniotomy as a choice for the treatment. So here you can see this is the sign that you are going to see on the epidural hematoma. And what is the another important point that you have to remember? These patient will be having the lucid interval. What does mean by the lucid interval? Yes, the patient lucid interval means the patients whoever is having the accident, suddenly they will be going into the unconsciousness. After the 5 minutes or the few minutes, they will be regaining the consciousness. The patient like everything is normal, but unfortunately, again after the 1 hour or the half an hour, the patient will be going into the loss of consciousness. So loss of consciousness and loss of consciousness. This is known as a lucid interval, only classically seen in the epidural hematoma. And subdural hematoma, S for subdural, S for sickle shape. Okay, so the sickle shape will be looking like this only now. So this is the hematoma. So this will be also in the sickle shape, that is it is going to present, and this is due to veins, and it can be chronic also. And Hrithik Roshan also during his one of the shoot, he also suffered from the subdural hematoma, and he has treated after his shooting only, not immediately, right? So this is what the subdural hematoma. It can be stayed for the long time also because of it is due to veins. Next, it can cross the suture lines, and the crescent shape that you are going to show, note the lucid interval seen, and it is always the craniotomy is the ultimate choice for the patient. Next, another important score that you have to remember is the triage. Let's see the first triage. So red color triage is the immediate and emergency that you have to treat this patient within 1 hour only. Yellow color is urgent. It can be delayed, but it can be delayed. How can you delay? For example, stabilize the patient and then you can just work up within the day. Next, green color is the minimal injuries. It is a very minor injuries, only the first aid, lacerations, bruises that can be treated. Black color, the patient is already dead. We cannot do. So that is the black color triage. Next, Glasgow Coma Scale. Glasgow Coma Scale is recently also asked in your INCT examination. So Glasgow Coma Scale, we will be looking for the eye, verbal response, and also the motor response. Eye, in the eye, there is a 4 points. Okay, E4, V5, M6. Total 15 points that we are going to give for the patient. For example, the one is none. One is none for all the patients. One is nothing. And 4 is normal. So whatever the highest number in the each one, that is normal. For example, in the eye, the patient is spontaneously opening. So patient is telling where the injuries happen. Patient is telling where is the pain is feeling. So that is the spontaneous. But the patient is only responding to our speech without asking, he is not responding. Then you have to give the 3. And to the pain, whenever you are pressing particular injury, the patient is responding. That is the pain. Next, none is 1. Verbal response, patient is well oriented, time, place, injury, everything the patient is telling. Patient is confused actually where he was, why he was brought. He doesn't even remember that the event is happened, the injury is happened. So that is confused. The patient is telling the inappropriate words. Okay, that is the 3. Incomprehensible sounds, only the patient is making the sounds, then it is 2. Next, motor response, obeys the commands, that is 6. Localizes to the pain, that is 5. And flexion and withdrawal is 4. Abnormal flexion is 3. Complete extension is 2 and none is the 1. So abnormal flexion is known as a decorticate position, and this is the decerebrate position. So if the patient is in the decerebrate position, it is absolutely the patient is going to die. Next, coming to the one by one system wise tree, the protocol that you have to follow. First one, that is the pneumothorax. Pneumothorax can be multiple times, right? One is a simple type. It could be even in the normal human beings also, due to internal factors also, the simple pneumothorax. One of the examples is continuous cigarette smoking. It can also cause a simple pneumothorax in the patient. Tension pneumothorax. Tension pneumothorax is mostly associated with the trauma condition only. And open pneumothorax, because of the open wounds, rib fractures, that is seen in the open pneumothorax. So how the patient pneumothorax will be seen? For example, the patient is having the lung injury. What happens? The pleura is open. So the once the pleura damage is happened, so the lung will be sucking. Okay, so the lung will be sucking inside. So the pressure between the intrapleural and the intrathoracic is deranged, so the lung is going to become, right? This is how the patient will be presented. So complete air only, you cannot see any lung markings. That is what's seen in the patients of the pneumothorax. Sudden dyspnea, chest pain, decreased breath sounds, hyperresonance due to only air is present. And what we can do in the pneumothorax patient, on the X-ray you are going to see tracheal deviation and distended neck pain seen. An immediate treatment that you can do is the needle decompression at the second intercostal space mid clavicular line to relieve the tension pneumothorax. And after that, you can insert in the chest tube. The drain is the ultimate treatment for this patient. Next, failed chest. What is mean by the failed chest? Okay? That the patient is having the more than two fractures which is associated same side of the ribs, that is going to cause the symptoms. For example, here you can see this is the break, this is the break. So adjacent side, same side, more than two. That is what's seen in the rib fractures. Paradoxical chest movement. For example, you are inspiring, you will be looking like a expiring. You are expiring, you are looking like a taking a breath. So this is a paradoxical chest wall movement will be seen in this patient. Severe chest pain, respiratory distress, and pulmonary contusions will be also presented. Treatment is give the oxygen, pain control, intubation, and the ventilation, and surgical fixation is immediately done. Until then, what we can do, we can cover with the to avoid the more and more pneumothorax cause, we can cover with the cover. Okay. Next, cardiac tamponade. In the cardiac tamponade, the most common cause is always trauma. Rarely in the other cases, in the MI or other conditions we will be seeing, but the most of the times it is trauma only. So the patient will be having the symptoms. What is the symptoms, guy? Hypotension, jugular venous distension, and muffled heart sense. This triad is known as a Beck's triad in the patient. What is the other symptoms? That is a pulsus paradoxus. So systolic blood pressure will be decreased even more during the respiration. Immediate treatment is initial resuscitation should be done for the patient, and intravenous fluids to improve the patient. For the preload, that has to be improved for the patient, and administer the immediately you have to evacuate that fluid to avoid the cardiogenic shock. So that is a pericardiocentesis that has to be done for this patient. Next, another last important, that is the abdominal trauma. Okay, that is the abdominal trauma. So in the abdominal trauma, the most common organ, if ever the question is asked, that is the spleen. Okay, spleen is the most common overall organ is involved. But if it is a penetrating injury, the most common cause is the anterior abdomen. So the more anterior, liver will be injured in this patient. Next, we also remember, right, seat belt injury, that is going to cause the mesentery. And water blast injury, this will be causing the intestines. Okay, blunt trauma is also spleen only. Blunt trauma is also spleen only in the patients. These are the one of the points that you have to remember. Next, whenever you see these patients with presented, we have to go for the fast. So what is mean by the fast, guys? This is the focused assessment using the ultrasound in the trauma. That is what we are looking here. So here you can see immediately you have to take the ultrasound and check the any free fluid or the blood internal bleeding is happening or not, that you have to check. First, check with the pericardium. Cardiac tamponade is has to be ruled out. Next, right upper quadrant, liver injury, right left upper quadrant to spleen injury, and suprapubic area, any internal bleeding that is causing the peritoneal buildup, or the right anterior thoracic or the left anterior thoracic. So if ever this is having, the fast will be only including of the four. Okay, this is the fast. This is fast. If the thoracic is involved, then this is a E fast, extended fast, which will be using in the protocol. This is also the pattern that is asked, guys. One step out, whichever the steps that you have to follow. Next, let's see how you are going to assess the patient. For example, let's say that the patient is came into you in the ER with a blunt trauma after the patient is got the injury. What you have to do, first and foremost, you have to do the fast. That has to be done to check any free fluid, liver injury or the spleen injury. You have to check if ever the fast is positive for this patient. If the fast is positive, then you have to check the patient hemodynamic status, and if the patient vitals is stable, then we can go for the CECT. That is the ultimate investigation of the choice for the stable patient. But if the patient is not stable, then we have to go for the laparotomy as soon as possible. To the patient has to be taken for the condition, right? At least remember this point. Okay, this cannot be, because nowadays the diagnostic peritoneal lavage is not usually done, guys. So this you have to remember. Next, we have the penetrating trauma also. So in the penetrating trauma, how you are going to classify, right? So for example, again you have to do the fast, right? If the fast is positive and also penetrating, you don't remove the penetrating whatever. For example, if you see the knife or if you see any object with the fast, you should not remove. Always you have to go for the surgical OT only. Always you have to go for the surgical OT. You don't remove that penetrating object in the emergency room, because it can cause the severe bleeding risk. So that's why it has to be avoided. That is the one point that you have to remember. Next, another thing that you have to see is the is it let's take the object knife is seen and also bleeding is presented. Next, you have to see, is there any breach? For example, peritoneum is visible or not. Okay, peritoneum, yes, it is visible, and peritoneum is not visible. If the peritoneum is not visible, then we can go for the CECT. CECT, and whatever the local suturing can be done, we can close. But if you see CEC, the peritoneum breach is seen, intestine is injured, or the patient is having the omentum mesentery that is coming outside, then we have to proceed for the laparotomy. Laparotomy should be done immediately in this patient. So this is how penetrating trauma and blunt abdominal trauma that we are following in these patients, right? This is how you are going to manage these conditions of the trauma condition. Next, another important question that is asked previously, if ever you see the liver injury, if it is the bleeding is increasing so much, if you want to stop the bleeding, you can perform the Pringle's maneuver. This is the Pringle's maneuver. So this Pringle's maneuver is going to block the all the hepatic artery and the hepatic vein. So here you are going to block. So hepatic artery and the hepatic vein, common bile duct, which will be compressing this portal triad, and that is going to control the bleeding of the patients with the liver trauma. And this maneuver, this space is known as a foramen of Winslow. This is known as a foramen of Winslow, that is seen in this patient, right? Ultimately, this is the how the treatment is given for the different types of the injuries. Next, we also have the retroperitoneal injury. Retroperitoneal injury. So in the retroperitoneal injury, we have the three zones. Okay, zone 1, zone 2, and zone 3. So in which is the most commonly injured? So the most commonly injured is the zone 3, which is the most commonly injured. What is the most severe? So the most severe is a zone 1. Most severe is the zone 1. Why? Because it is involving the major vessels like your SMA, IMA, iota, and also inferior vena cava, all will be seen in the this only, right? In the second one, second zone 2, most of the times which will be including of the kidney, that means lateral side and also renal vessels and ureters. This is used, and for the most common is the pelvis. So the surrounding structures like urinary bladder, right? These are the commonly used for the conditions. So this is what the retroperitoneal injury. Now we will be discussing of the vascular surgery. In the vascular surgery, the most important topics such as peripheral vascular disease, GVT, and also Berger's disease. Okay, so peripheral vascular disease, if you see, so the disease only the cause is atherosclerosis. Okay, atherosclerosis in the peripheral, or let's say in the lower limbs. So this is going to cause the chronic limb ischemia and also the reduced blood flow to the lower limbs. So how the patient will be presented? Most of the patients will be presented with the pain. Okay, calf pain. So for example, if you see angina pain in the heart, you call that as a angina. And same that if you see the lower limbs pain, you will be calling that as a claudication. So the patients will be having the intermittent claudication. And also sometimes if the peripheral arteries if severely blocked, we will be seeing the absent distal pulses. So what are the causes, some of the symptoms that we are going to see in this peripheral disease? Pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia. Okay, temperature changes also we will be seeing in these patients. Next, Boyd's classification. What is the Boyd's classification, guys? We are checking the patient's presentation. On the clinical examination, you are checking how the patient is having this pain symptoms. Is the patient is doesn't have any pain but still he is having the blocks to the atherosclerosis, or the patient is having the pain for the initial walking, or the patient is having the severe pain even after the walking also, or the patient is having the intense pain and maximum pain cannot continue further. Okay, so we are actually looking for the Boyd's classification depends on the patient walking. Even though patient is walking, there is no pain at all. So the one grade is initially the patient is walking, the pain is there, and after that the pain will be subsided. That is the 2. That is the 1. And the 2 is the patient is having the moderate pain. After taking the rest, it is somewhat decreased. And third pain, it is even associated with the rest also. Okay, even associated with the rest. And fourth pain, even the less than 100 meters or the 100 centimeters also the patient cannot walk. Okay, that is the maximal pain which cannot continue by the patient. Next, investigations. In the investigations, clinical investigations, if you see, we have to check the anchiobrachial index in the ankle and also in the brachial. So we will be checking the difference of the between the peripheral resistance and also the iota function. Is it present the good or the bad in the upper limbs and the lower limbs? So if you see more than 1, that is considered as a normal value in the patients. And if it is less than 9 to 99, this is a borderline. If it is less than 7, it is a mild peripheral artery disease. If it is less than 5, this is a moderate type. And even more less than 5, this is considered as a severe PAD, impending gangrene. So if it is still continuous, we may have to amputate the patient leg also. Next, another important classification, guys. This is a SEEP classification. For all the venous disorders, we will be looking for this SEEP classification. So just now we completed the arterial. Okay, now we entered for the venous classifications. In the venous classification, at least this SEEP classification that you have to remember. What is mean by the SEEP? C for the clinical manifestation, E for the etiology, A for anatomy, and P for the pathology. So C1, the patient on the lower limbs is having the telangiectasias and also reticular vein is visible. And C2, which will be involving of the varicose vein, and these are the recurrent varicose vein, then R has to be added. C3, the patient is having the severe edema. C4, the patient is having the pigmentation for the C4A, C4B, lipodermosclerosis, and C4C, this is the corona phylactexia, this is for the C4C. And C5 is already healed ulcer. C6 is the active venous ulcer that is presented in the patient. Next, EC, etiology, is it congenital? EP, it is a primary. ES, is it the secondary? Next, anatomy, superficial venous system, AS, and AD is the deep venous system, AP is the perforators, and pathology, is it the obstruction or the reflexes? So at least these points are very important. So clinical manifestations are very much important classification. Next, what is the first line of the therapy? Doppler ultrasound is coming. Even if you see the OP patient, you can't tell the patient to take the severe angiogram kind of. So what we will be giving the patient? Take the ultrasound for the patient. Next, we have the gold standard therapy, that is a digital subtraction angiography. Digital subtraction angiography can be also done in this patient. Next, Burgess disease. Burgess disease, sometimes it is asked. Burgess disease, the patients will be seen with the young male smokers less than 45 years. And if it is more than 45 years or the more than 50 years, then it is a atherosclerosis. So Burgess disease is an vasculitis. What is it is going to involve, guys? Medium sized vasculitis and also the small vessel vasculitis. And most of the times the patient will be smoker only. Okay, in the history you are going to see the smoker. So these patients will be having the severe distal limb ischemia, rest pain in the fingers and toes, Raynaud's phenomena is seen, and absent distal pulses, which will be presented in the patient. Next, investigation of the choice is the angiography, and where you are going to see the corkscrew collaterals will be observed. And treatment, absolute smoking cessation has to be started on the patient, and vasodilators can be given, and also analgesics for the pain. Surgical options, we are going to amputation, and sometimes we can also do the lumbar nerve lumbar nerves can be deactivated. Okay, that can be also done for these patients. Next, DVT, deep vein thrombosis, the formation of the thrombus in the deep veins, typically in the lower limbs, that is present in the deep vein thrombosis of the patient. And how the patient will be presented? The patient will be having the history of the trauma or the hypercoagulability, especially in the congenital conditions like factor V deficiency or the recent surgery, immobilization due to bed rest, obesity patients, malignancy patients, sepsis, oral contraceptives because it increases the thrombosis, and pregnancy is a hypercoagulability state, smoking, immobilization. All this can be triggering for the deep vein thrombosis of the patient. Right. Next, what are the signs and symptoms that you are going to see? The patient will be having the unilateral pain that will be seen in this patient. Tenderness is seen, and warmth tenderness is also seen in this patient. So there is a sign that is present, that is a Homan sign. What is the Homan sign? When you press the patient calf pain, when you the patient is doing the dorsiflexion, the patient will be having in the pain in the calf. Okay, so that is the sign that can be seen in the Homan sign. And the investigations, the gold standard is the venography that can be done for this patient, and Doppler ultrasound is the first line, and the D dimer is high negative predictive values is seen in this patient. Next, treatment. Coming to the treatment, the most of the times the patient will be given as a anticoagulants only. Okay, anticoagulants can be given for this patient. For example, anticoagulants such as low molecular weight heparin can be given, or also warfarin also can be given. And IVC filters, intravenous catheter, this filter can be used if the patient is having the contraindications for the anticoagulation uses. And compression stockings we use for the prevention of the post-thrombotic syndrome kind of symptoms. Next, pediatric surgery. Pediatric surgery, the most important one, the idiopathic hypertrophic pyloric stenosis. What is the most common cause, guys? It is just hypertrophy. For example, you have the pylorus like this. Okay, so the flow is clear. So what happens in this patient? The pylorus will be severely obstructed and narrowed. Okay, so the flow will be decreased here. So what are the muscles? Is it the longitudinal or the circular? So the muscles here is the longitudinal. Sorry, the muscles are the circular muscle. Hypertrophy is seen in this patient. This will be causing the obstruction in the patient, and obstruction is precipitated. For example, if you see, when you are giving the food for this patient, that is already obstructed, so food cannot move further forward. So what happened? The food will be going to outside. So how the food will be outside? With the vomiting sensation. So the patient will be having the projectile vomiting, which is non-bilious, because the pylorus is already stopping the patient. Food is not yet entered to the duodenum to mix with the bile, so it is a non-bilious. And some of the factors that can be associated with the significance, erythromycin use or the firstborn male child, which is associated with the risk factor. And on the examination, you will be seeing the olive shaped epigastric swelling will be seen, and visible peristalsis is also seen, and severe vomitings can be causing the derangement in the electrolytes. How it is presented? Hypokalemia, hypercholeremia, metabolic acidosis paradoxical paradoxical aciduria. Right, this is seen in these patients of the idiopathic hypertrophic pyloric stenosis. And investigation of the choices, the gold standard is ultrasound, and surgical treatment is a Ramsted's pyloromyotomy. And there is other question is also asked, what is the treatment of the choice for the fluids? So in this patients, the fluids is most commonly given for this patients is the NS. Okay, normal saline is given for this patient to decrease so the further damage for this uh, electrolyte imbalance we have to give for NS for this patient. Next, intussusception. So intussusception, this is the most common abdominal emergency in the children. And what is the most common cause, guys? It is just telescoping of one part of the intestine into the other. For example, this is the intestine, this is the proximal part. So the distal part is going to have the intussusception like this. So this is what intussusception obstruction will be seen in this patient. So the most common junction is the ileocolic junctions in the children, but if you see the like adults, it is a colocolic region. Right upper quadrant, pain, vomiting, skew and jelly stools. This is the common triad of the intussusception. Investigation of the choice, again ultrasound is the gold standard. And what is the treatment? IV fluids, parenteral therapy and surgical reduction. And most of the times, so the investigation of the choice and also the treatment of the choice, which will be enema only. So just by giving the air contrast edema or the water contrast edema, the telescoping will be decreased. Next, Hirschsprung disease. Hirschsprung disease is, it is a congenital anomaly, especially the neural crest cells is failed to migrate, so the ganglions is not formed in the enteric nervous system, which is going to cause the obstruction here. So this entire part is obstructed because there is no nerve ganglions. And what is the most common site? Rectum is the most common site. The patient will be, the newborn will be having the delayed stools more than 48 hours with the abdominal distension. On the PR examination, sudden expulsion of the meconium due to transient dilatation with our fingers. And best investigation, gold standard, that is a rectal biopsy. On the rectal biopsy, you are going to see the ganglions is absent, hypertrophic nerve fibers, and acetylcholinesterase is positive. Treatment will be early resuscitation. What we can do, we can do the colostomy or the ileostomy as part of the to relieve the obstruction, and after the 1 to 2 weeks or the interval time, we can reduce this, we can resect this, or we can connect with the normal. Here it is a normal and here it is a normal, so we can connect by the resections. Next, congenital diaphragmatic hernia. Just before also in the two other subjects also we have discussed. What is the defect here? The pleuroperitoneal membrane is properly not closed. So that is why the patient will be having. Which is the most common side? The left side is the most common. What is the type? That is a Bochdol's hernia. And this is going to cause the pulmonary hypoplasia, which is leads to the hypoxia, pulmonary artery hypertension, and the patient death. So on the examination, you will be hearing the bowel sounds in the chest and also barrel shaped chest and scaphoid abdomen, because the abdomen parts are already migrated to the chest. So in the chest x-ray, yes, the bowel loops will be seen here. Treatment will be stabilize the patient, and after the stabilization, you can go for the surgical repair. And what is contraindicated in this patient? The bag and mask ventilation is contraindicated in this patient. Next, tracheoesophageal fistula. Tracheoesophageal fistula, for example, this is a trachea, this is the esophagus. So what happens? Esophagus has to be in the separate, trachea has to be separate. What happens here? So the esophagia is atresia. Esophagia is not properly formed in this patient. So sometimes what happens? This trachea is formed, but this will be connecting. So this is what tracheoesophageal fistula. Okay, so the esophagus is properly not connected, and this is what's seen in this patient. Next, the thing that you have to remember here is the what is the most common type. Esophageal atresia. For example, this is the esophageal atresia, and this is the trachea. This is the trachea, this is the esophagus, and it is connected here. Okay, this is connected here. So this is what the most common type. What it is telling? Esophageal atresia with a distal fistula. Next, on the examination, how you are going to identify this? The patient will be having the frothy secretions from the mouth because he cannot swallow the saliva. Aspirational pneumonia can be associated, and failure to pass the nasogastric tube. Here also you can see the examiner or the doctor cannot pass the nasogastric tube. And on the X-ray also you will be seeing the same coiled tube will be visible. And the correction will be surgical correction with the ligation of the fistula and the anastomosis of the patient, right? And another important condition is the duodenal atresia, right? Another important part is the duodenal atresia, most commonly seen in the Down syndrome patient, right? Down syndrome patient. So the duodenum is not properly formed, right? Duodenum has the four parts, right? In the four parts, one of the part will be not not properly formed, that is going to cause the atresia and also obstruction in the patient. And in the duodenal atresia, you have to remember the one point, that is what is the X-ray findings. X-ray findings will be double bubble, double bubble sign, right? Double bubble sign will be seen. And jejunal atresia, this will be presented as a triple bubble sign. This will be presented as a triple bubble sign, right? These points are very important, guys. So this is our lecture, so please do read all these important topics, and also make sure that you are going to practice this. And scorings, classification, everything is very, very important. So those who are new to this channel, please do subscribe and share with your friends. And also don't forget to watch the part 2 tomorrow, and also don't forget to watch the remaining videos. So these videos will be helping you a lot in the final examination. I have that confidence because it has been proved in the previous examination also. So please do subscribe, share with your friends, do like the video, and also don't forget to watch the tomorrow video, guys. Until then, see you guys. Happy preparation.